Yeah, and thank you everyone once again for joining us. Today we'll be having another discussion on methadone. Before moving on to the session, as everyone will be present right now, we have received case presentations from most of you. And most of the presentations are questions, discussions regarding the very basic topics or very basic questions. Please go through the session topics and send relevant presentations. Like we have several sessions which has been sent to you. Just see which one you are choosing, which topic you are choosing, palliative care in cardiology, nephrology. Choose accordingly and please send us case presentations. We'll make a list and share it in the WhatsApp group. Who have sent, all of the, we have sent scenarios which doesn't match with any of these sessions. So please go through the session topics and send us relevant topics as soon as possible. So sorry, Dr. Sunil and Theo, I just had to mention this in the beginning, otherwise people might lose in the end. So thank you so much for both of you for joining again. Thank you, Theo, for joining us from the US. So today we have initially Theo's presentation followed by discussion. Again, presentation by Dr. Sunil and some methadone stories from our setting, and case presentations and calculations by Theo. We'll have some time in the end for discussions and question and answer. So please make use of that time for asking your questions and clearing your doubts. Thank you so much. Over to you, Theo.
And thank you again for joining us today for today's session. So today's sessions will be focused on methadone calculations. Are you guys able to see my screen?
Yes, it's visible.
Okay, great. So the learning objectives today will be identifying the safe monitoring parameters of methadone, which we reviewed a little bit last time, and then creating a safe and effective therapy plan to initiate methadone, and also developing safe and effective plans to titrate and adjust methadone doses. So just for a very brief pharmacology review, I'm sure many of you may remember this, but just as a refresher. For the bioavailability for methadone, it's primarily absorbed very well orally. And then there is some minimal sublingual, but if given syrups, patients generally are going to be absorbing it and trickling through their throats and being absorbed through the GI system. And then in India, it only is currently available in the syrup formulations, but that can also be administered rectally if needed. And then in other areas, it may also be available in IV formulations, which can be given IV or sub-Q. And then for the half-life of it, like we spoke about last time, it is a biphasic distribution. So that is a peak once initially absorbed in the serum or the blood serum, and then it is very well distributed into different tissues, which leads to this two-compartment model and leads to that biphasic pharmacokinetic model. So generally speaking, the half-life for most people are around 8 to 59 hours. But again, in people with severe hepatic impairment, it can be as long as 120 hours. And then analgesic duration or the frequency that we use in analgesia is dosing every 8 to 12 hours. So for steady state pharmacokinetics, I'm sure many of you are aware, typically when we give any oral dosing for immediate releases, if we continue to give doses around the clock, eventually what you'll see is with the blood serum levels is it'll start to level out, and that's what we consider as steady state. And typically a rule of thumb is 3 to 5 times the half-life is the time it takes for us to get steady state. So in IR morphine, that would be a much shorter time period. But if we use extended release formulations, then it will clearly be longer until we get to that time. And the extended release either can be formulated so the chemical half-life may be shorter, but they may formulate tablets so it's a slow release, which may affect that. And in other medications like methadone, its chemical or base half-life is long. So it's not necessarily that it is being formulated to make it last longer than normal. Its base compound just has a longer half-life. So now going into methadone conversions, there's a few key things to note that makes methadone unique versus other opioids. Methadone does not have a linear conversion ratio. So it's not a 1:1 or 1:2 because of its unique properties. Remembering when we talked about the mechanism of action, the NMDA antagonism may provide benefits to help reduce some of the opioid tolerance, hyperalgesia, and also contribute to neuropathic pain benefits. So from many different studies and over the times, there have been different suggested methadone conversions, and many of you who are already practicing may be familiar with these different ones. However, the one that we'll be reviewing today is the white paper consensus, which gives a very good overview of how to do methadone conversions, and it's nice and conservative, but also simplifies the process to make it much easier to utilize. So one of the most important things when we do these methadone conversions is making sure that we are calculating total opioid requirements and then determining how much we want to utilize for a basal amount. And then we move forward with doing these calculations. And then once we do provide patients on methadone, we want to make sure that we are providing sufficient breakthrough medication or SOS dosing while it takes time for patients to reach steady state on methadone, and making sure that patients are receiving adequate pain management. So with the white paper consensus, it breaks it down into two main categories for opioid naive patients versus opioid tolerance. So the first definition is opioid naive patients, and these would be patients that are receiving a total oral morphine equivalence of 60 milligrams or less than 60 milligrams a day. So this can be someone that has not started methadone before, but you think may be a good candidate, or they're on very low amounts of SOS dosing, but you think these patients are a good candidate for methadone. So initial dosing can be anywhere between 1 milligram Q 12 hours or 2.5 milligram Q 8 hours. So typically for your older patients or more frail, or maybe patients with severe hepatic impairment, you may want to err towards the more conservative dosing to start off at 1 milligram Q 12 hours. Now going on to our opioid tolerant patients, it further breaks it down between two categories. And between these two categories for conversion ratios, there's a few key things. So for patients with an OME of 60 to 199 milligrams or less than 200, and patients that are less than 65, then we would use this conversion ratio of 10:1. On the other end, and I want you to focus on this or statement, for patients that are using 200 milligrams OMEs or more, or if patients are over 65 years old, then we would use this 20:1 conversion. And the reason for that, right, when we talked about is methadone can help with opioid tolerance and also additive neuropathic pain benefits. That when patients are on such high doses, because it may reduce opioid tolerance, we utilize this conversion in anticipation that it may actually lower OME requirements. And then for patients that are 65 years and older, again, they may be metabolizing methadone slower. So that's why we go on to this more conservative 20:1 ratio. And then again, just to review, this on this side for the 10:1, it's an and statement. So they should be younger and a lower opioid requirement. So now that we've gone through these conversion ratios, another few things to keep in mind is regardless of the conversion factor or OMEs the patient's on, when you do the calculations, the maximum initiation dose you should ever start a patient on is no more than 40 milligrams a day in divided doses. And also this conversion ratio is nice because it already includes incomplete cross tolerance of opioid conversions. So you don't need to make further reductions when utilizing these conversion ratios. And then the other thing is this conversion ratio is only from other opioids to methadone, and it should not be used the other way around because this is a conservative approach. And once you have a patient on methadone and you feel that there may be need to make dose adjustments, the recommendations from the white paper consensus is for patients currently on methadone doses of a daily dose of less than 30 milligrams a day, then you can do titrations of 5 milligrams a day. And for patients utilizing 30 milligrams OMEs, 30 milligrams of methadone a day or more, then you can use titrations of 10 milligrams a day. In regards to how often you should be waiting until you do any dose titrations, again, that's going to be based off of our anticipated pharmacokinetics and steady state for patients. So patients that have normal liver function, then we would stick to that recommendation we spoke about last week about no sooner than 5 to 7 days before considering making these dose titrations for methadone. And patients with hepatic impairment, or if they are elderly, then we would also recommend no sooner than 10 to 14 days because we anticipate they would be metabolizing methadone at a slower rate. And then again, just to review, like we spoke about last time with drug interactions, the major CYP substrates or the cytochrome substrates that we want to look for is if there's any interactions with 2B6, 3A4, 2D6, 2C19, and then the minor cytochrome P450 is 2C9 and 2C8. And for any inhibitors that we're starting, or if we're stopping an inducer, then empirically reducing the methadone dose by 25 to 33%. And then on the other end, if we're stopping an inhibitor or starting an inducer where we anticipate that they may metabolize methadone faster, we also recommend that there are no anticipated increases in methadone, but we just monitor and then making sure that you're providing adequate breakthrough medication and then making titrations once you reach the new steady state with these adjustments. And then just as resources for the slides, if there are concerns or questions about what medications may cause these interactions, a good resource is the Flockhart table. And I provided the link here. And there's a comprehensive list of medications that are known CYP interactions that you can utilize and compare with. And additionally, as we spoke about last time with QT prolongation concerns, you can use this website called Credible Meds, and this is a very nice, reliable, and comprehensive list of medications that have no QT prolongation risks. And so with this presentation, it is a little short, but we'll go through cases to practice through all of this. But with these conversion ratios, they are very conservative. So I think many of you can feel very comfortable and not too worried about utilizing this and utilizing methadone for adequate pain control. And I just want to open up some questions.
Thank you to you. So if anyone has any questions, we have some time for discussion. There is no question in the chat as of now, but we'll wait for a few minutes so that people can type and ask questions. Or you can unmute yourself and talk. Theo, Dr. Meenakshi is asking, can you just go back to the previous slide? Is this the one, Dr. Meenakshi?
Yes, yes. Thank you. Yes, thank you. This one. Thank you.
Are there any other questions, or shall we go ahead? Yeah, there is a question from Dr. Gajis. Is there a role for loading dose also, as it has it takes long time to titrate? No, it's no questions are silly, Dr. Gajis. Like everyone has all this kind of doubt.
Yeah, then that's an absolutely great question, and I wouldn't say that's silly. So that makes sense with a lot of different medications, right? So if we do things like vancomycin or some other drugs where we would try to do an initial loading dose in order to get adequate serum levels to get to kind of steady state faster. However, for methadone, typically we actually don't recommend to do a loading dose since we want to safely utilize methadone and make sure that we're giving sufficient time. I think generally speaking, we usually just use the dose that we would and allow adequate time for the steady state, just because of that being a more conservative and safe approach to it. Just because when we're first initially starting methadone, we want to see how people will respond to it versus doing an initial large load, which may add some additive risk. And then while we wait for adequate pain relief and getting steady state, we would be using the short acting opioids, so like morphine or fentanyl, to kind of act as the loading dose to provide adequate pain relief while methadone on the background is starting to build up.
Dr. Gajis, I hope if that's not clear, just type it in the chat. And another question, is the same dose and conversion applicable to methadone given by other routes?
So I would say when you're doing the conversions, when we're doing these dose conversions, it's oral morphine equivalents to oral methadone. If you're using other formulations such as IV, then I would keep in mind when we spoke about IV to PO, when we're going from PO methadone to IV, then it's a 1 to 0.5, so half conversion. But when you're going to IV to PO, then you would go to a 1 to 1 0.12 conversion, right? So whenever we're making these changes, we always just take a cautious and conservative approach, just because there is a little bit of variability, because we don't know if how they may respond. So that's just why we always take the approach, because we can always go up on the dose. But if we go high, you can't necessarily go back after you give the dose if there is concerns of causing a safety issue. And I believe Dr. Deepak asked to explain once more why we can't use the conversion rates in reverse. So the reason why we don't go in reverse is because these conversion ratios are very, very conservative. So it's a 10-to-1 to 20-to-1, which are very conservative. So we're really shrinking the dose so everyone can feel very comfortable and safe with using with methadone. But if you go around, right, if you do a conservative ratio, but then you switch it, then that means it may be more of an aggressive one going the other way around. So typically, if we're doing a methadone to morphine conversion, there's some studies out there and there's a little bit of variability, but some say it's anywhere between a 3 to 4.7 ratio going the other way around from methadone to oral morphine.
There is Dr. Meenakshi is asking, it's the same formula for the pediatric patients also.
So with pediatrics, I mean, with conversions, I think these were mostly studied in adults. I may need to defer to Dr. Sunil on his experience with pediatric patients, but I would anticipate with these conversion ratios, they are conservative and I anticipate it. But again, I will probably defer that to Dr. Sunil. And then typically for pediatric dosing, usually it's initiated on a weight-based versus just standard dosing approaches.
I think we can move on to the next part of today's session. Probably.
So, thank you, Sridhari. And before moving on to the presentation as such, we have some polls. So Priya will launch the polls, and I request all of you to do this. So there are 6 questions. Mr. Priya, can you launch the poll?
Yes, sir. Launch the poll, right.
All the questions has variable responses. Confidence level from 3 to 10, and I see about 8 participants have methadone in their institution. So I wanted to do this because now we have completed the theoretical aspect of methadone. So I just wanted to see how much confident I am. Because now what I am going to tell you is my experience or our experience of starting methadone for patients who has severe pain or do not have pain relief with other opioids, or if they have toxicities, or if they have complicated neuropathic pain. um, so when you also complete this, you will have many doubts regarding how to start methadone, how to find a patient for whom to start methadone, and what will you do for drug interactions? Is it safe? Actually, even though methadone was available to us, we were actually um, thinking how not to start methadone, because we were with various side effects of methadone, like drug interactions, prolongation of QT interval, toxide points, mm, all those things were really making us afraid to start methadone. What I want to do is I will go through our experience on starting methadone, which will definitely, I think, will help you to understand how everybody goes through when you get methadone for the first time. So this was one of our early patients. I think she was the first patient for whom we started methadone. So this was a young lady with Ewing sarcoma, uh, who was diagnosed with Ewing sarcoma in 2016, and she received chemotherapy and radiotherapy for the lesions. And she was okay for almost 2 years, but then she started having pain on her leg and back in 2018. That is after 2 years, and the doctor advised to MRI, which indicated that there is disease progression. Uh, and you can see that also compresses the L5 and S1 nerve. The PET scan also show pleural metastasis. Uh, then uh, this patient was started on morphine 10 milligram 4 hourly and SOS, amitriptyline 25 milligram HS. These all were started from another palliative care center. And then because she didn't had proper pain relief, she was started on epidural analgesia with ropiacaine and morphine. Initially, she had some relief for about 18 hours, but later the pain relief became less, and she was in distress. And they were also unable to keep the epidural for long, but they kept it for almost 2 months by reinserting at other side. But um, um, uh, after 2 months, they were planning to take out the epidural catheter. So they started her on 20 milligram of morphine 4 hourly and SOS dose. And then they removed epidural catheter and also increased morphine to 40 milligram 4 hourly and SOS. Amitriptyline was added 25 milligram HS, pregabalin 75 milligram HS. Patient didn't had satisfactory pain relief, but she also had delirium and myoclonic. This patient was actually living in the first floor of a home, uh, and she was unable to move from the bed, and she is unable to come out of that room, because whenever she moves, she will have severe pain. So you can see the pain distribution. This is the pain at rest. But you know that if we are in a bed, we want to move very frequently. So whenever she moves, the pain goes up to 10 by 10. So she described it as pain starting at low back. It is like burning and shooting. She has relief on lying down, but increases with any movements. So her mobility is restricted. She was also unable to sleep at night. So um, uh, we thought she would be an ideal patient to start on methadone. Um, I just want to ask you, what are the indications and to start methadone in this patient? Can anybody tell me?
No adequate relief with opioids, sir.
Yeah, no adequate relief with opioids.
And also toxicity, sir, because he has delirium and
Yeah, toxicities of opioids. Yeah, what else?
the neuropathic pain also was not in control with
Yeah,
the gabapentin.
neuropathic pain. Yeah. So we plan to start her on methadone. But before starting methadone, we have to ask the patient a few questions. And we have to find out whether there is any family history of sudden unexplained death in the family. And another thing is there a reliable caregiver for administering the medication? So she had both. There is no family history, and she had a reliable caregiver. So we did an ECG, which was uh, normal, QTC interval, and we also did electrolytes, which were normal, calcium, potassium, and magnesium. So the next question was, uh, there are actually many methods to start methadone. So if you look at the literature, you will see these methods: 3-day switch, um, then a rapid conversion stop and go method, uh, ad libitum stop and go method, German model outpatient titration. So we were confused which method has to be used. And there is a systematic review which says, which was done in 2015, which says there is currently no consensus based on empirical research as to what is the safest and most effective method for reversion to methadone from another strong opioid. So this was all confusing. We were also confused, but we had that many use 3-day switch method. So what is 3-day switch method? In 3-day switch method, you will calculate the total dose of methadone, and on the first day, you will add 1/3 of this total dose of methadone, and you will reduce 1/3 of the dose of methadone. Sorry, 1/3 of morphine. On the second day, you will add another 1/3 of methadone. So totally it will be 2/3. And morphine you will decrease by 2/3. And on the third day, you will give full dose of methadone and you will stop morphine. So this is the 3-day switch method. But as we were starting in this patient on methadone, and this was our first experience, we were afraid actually. And so we didn't go for that method also. We did go for another method. You can see that how to calculate methadone dose calculation. So this is the equi-analgesic table which was present at that time. 2018. The white paper consensus method, which came in 2019. But when we used methadone for the first time, we used this conversion ratio. So in this patient, the total morphine equivalent daily dose, this patient was using 40 milligram of morphine 4 hourly. So total dose would be 240 milligram of morphine. And if you look at this conversion ratio, this patient is between taking morphine between 100 to 299. So the conversion ratio is 8:1. So 240 divided by 30, 8 means 30 milligram of methadone. But we also had to account methadone for incomplete cross tolerance. So 30% is the standard incomplete cross tolerance. So 30% of 30 milligram would be 9 milligram. So the total dose of methadone that we are going to use would be 21 milligram. So you can use this 21 milligram. Okay, so this is the 3-day switch. So suppose you are using 3-day switch method. The total dose of methadone you have to start is 21 milligram. So on the day 1, you will add 1/3 of the methadone. So 7 milligram of methadone you would add, and you will reduce the dose of morphine by 1/3. So that would be 160 milligram. And on the day 2nd, you will add another 1/3 of methadone. That would be 14 milligram of total methadone, and you will reduce morphine by another 1/3. That is to 80 milligram. On the day 3rd, you will give full dose of methadone, that is 21 milligram, and you will reduce the morphine dose by another 1/3. So total, the morphine will be 0. So you have to stop the morphine on the 3rd day. So this was the 3-day switch. So as I told you, we were afraid actually to start methadone like this. So we tried another method, which you will not get in any literature. This is because we were afraid. That's why we did like this. So this is what we do. What we did. We took 14 days to convert morphine to methadone. So on the day 1, we started her on 2.5 milligram of methadone, and we reduced 1/3, almost 1/3 of the morphine. So within 2 to 3 days, patient was able to sleep. On the day 7, we converted another 1/3, or added 1/3 of methadone. So we made it 5 milligram TID, and morphine was reduced by another 1/3. So it became 15 milligram Q for H. Patient had very good pain relief. And on day 14, actually, the patient who was unable to move from the bed, she actually came to our OPD by walk. So on the day 14, we increased the dose to 7.5 milligram TID. That is the total dose of methadone, and we stopped morphine. She had excellent pain relief. So this method is not described anywhere. So purely because we were afraid to start morphine because of the so many problems associated with methadone. And now if we would have seen her, then we would have gone for white paper consensus method. So according to this, what should be the conversion method? She's taking 240 milligram of oral morphine, and age is 30 years. So the conversion ratio would be 20:1. And the total dose of methadone is 12 milligram. So you can start with syrup methadone 4 milligram 8 hourly, along with SOS dose of morphine, that is tab morphine 40 milligram 4 hourly SOS dose. So this was the first patient whom we have started methadone. And next one was a 37-year-old man who had carcinoma of the buccal mucosa in 2018. And he also had another primary, that is papillary carcinoma of the thyroid, for which he underwent surgery and radiation. But in 2019, he had a level 2 nodal recurrence, and he underwent surgery for that. But then he had very severe pain. You can see the position of the patient, and he describes pain which starts inside left ear, going to lateral aspect of forehead, and then to submental region. He described it as pricking pain, and the pain score is 10/10. And another institution, they did extraoral mandibular nerve block 3 times, but without any pain relief. So you can see the mandibular nerve and the distribution of pain here. So that's why they did extraoral mandibular nerve block. But there were no pain relief at all. Then they tried on injection morphine, and which produced more of toxic symptoms. So they stopped injection morphine and started on morphine like this: 10, 15, 10, 30 milligram and 10 milligram SOS. And they also tried on various adjuvants, but they didn't had proper pain relief. So this was the medications when the patient came to us. Tab morphine 10 milligram, 15 milligram, 10, 30 milligram. Pantoprazole 40 milligram OD, ciprofloxacin 500 milligram BD, acetylopram 10 milligram BD, sarcopeptidase, diclofenac, bax, tab paracetamol 60 milligram, 1 SOS. So do we have any indication to start methadone in this patient? Anybody?
Yes, sir, because there's no relief with morphine, no, sir.
Yeah. Any other indication?
No pain relief is one response in the chat.
Yeah. That's also true.
So there are a few questions. We'll be taking that in the end, right? After your presentation.
Yeah, yes.
Okay.
And the patient has a neuropathic pain, isn't it? And actually, in head and neck cancers, you will get a lot of neuropathic pain. And methadone is really a good medication for those neuropathic pain. Okay, patient had also had morphine toxicities. So before starting, what all do you need to do for this patient? So you have planned to
Ciprofloxacin
start.
is to stop.
Sorry.
Ciprofloxacin is to stop, sir, because of interaction.
Yeah, that's true. Anything else?
Can ECG? Could you see?
Yes.
Serum electrolytes.
Yes. Anything
Especially
else?
magnesium calcium.
Yes. Okay.
Know the
So
history of-
you have to ask for a history of sudden unexplained death in the family. Is there a reliable caregiver? Then, as you told, ECG and electrolytes. But I would like you to take you back to the Theo's first class, where he told that the investigation, it should be according to the goals of care. So this patient with the 2 primaries and no treatment is planned from the oncology. So actually, he is fit for comfortable care. So our goals of care is comfortable care. So actually, should we do an ECG and electrolyte for this patient? Need not be. Okay. So some of you had raised concern with the ciprofloxacin. Any other concern? So these are the medications that was patient on this one.
And the prosole also. And the prosole.
Pantoprazole.
And the prosole. Okay. Anything else?
Escitalopram.
Yeah. So we have 3 medications which can produce interaction. One is acetylopram and pantoprazole and ciprofloxacin. But ciprofloxacin is would produce more interaction than acetylopram and pantoprazole. So ciprofloxacin, acetylopram, and pantoprazole. Okay. So this patient was taking 65 milligram of oral morphine, and the conversion ratio. This patient's age is 39 years, and so his oral morphine equivalent is between 60 to 199 milligram because he is taking 65 milligram of oral morphine. So the conversion factor would be 1/10. So total dose of methadone he required would be 6.5 milligram. So if you have only tab methadone, you can start 2.5 milligram BD, that is 5 milligram of methadone. Or if you have syrup methadone, you can start on 3 milligram BD along with morphine 10 milligram for hourly SOS. So the prescription would be like this. methadone, morphine, paracetamol. You can continue. And instead of ciprofloxacin, we changed to amoxicillin. Actually, this patient was put on acetalopram by another palliative care center, thinking that he is in depression, but his main problem was severe pain. So when he had pain relief, then there were no features that can indicate that he is in depression. So we didn't continue with acetalopram. We added bisoprolol and we stopped pantoprazole because that was not indicated. So this patient was started on methadone 2.5 milligram BD tablet. Patient had a good pain relief, but increased to 2.5 milligram after 5 days. So satisfactory pain relief. So 2.5 milligram BD was increased to 2.5 milligram TID, and then we increased it to 3.75, 2.5 to 3.75. Why I am showing this doses is because these were the patients for whom we started, or when we had methadone at the beginning. So we were not confident enough to increase the methadone which we practice now. So you can see we increased only smaller doses. You can see only 2.5 milligram increase at each step. So you will also face these problems, and then you will have doubts whether I should increase it to 5 milligram or something like this. So if you are not confident, go for a smaller increase. And I told you the white paper consensus method was not available at the time when we started giving methadone. But after the white paper consensus method has been published, we are using that method only. And we actually in 2018 we had methadone by February, but in that year we started methadone only for I think 7 or 8 patients, even though we had patients who had very severe pain. So that indicates we were not confident enough to start patients on methadone. And we had about 10 doctors. Nobody was much confident to start methadone. But in the next year, in 2019, we actually prescribed for about 25 patients. And 2020, we had more than 50 patients. So this indicates that when we become confident enough to prescribe methadone, the confidence will come only when you have experience. So the problem with Indian pain and palliative care physician is that many of us are not experienced with methadone. And when we started, or when methadone was available first in India, there were no palliative care physician, or maybe 1 or 2 who had some experience with methadone. So I just wanted to share this experience with you all, so that when you plan to start methadone, you can understand that okay, these problems are normal, and these are the problems we have to face. And you can also get help from at least I think there will be some less than 10 institutions in India, I think, is using methadone as of now. So I think I will stop here and will take questions.
Sir, I have a question, sir. I want to know whether you found any difference between the time you were scared to and after the white paper consensus. Was there any difference in your experience, apart from the confidence, regarding the patients? Were you finding any difference, sir?
No, I told you in the first patient we started with only a small dose, and we took 14 days to convert full methadone to full morphine to methadone. So it took 2 weeks to have good pain relief for the patient. But now we convert morphine to methadone completely on the same day, so that patients will have more pain relief by 1 week.
Okay,
So that is one of the difference that we can see.
okay, sir. Regarding side effects, or what were you scared of, sir? Like,
So I asked a few questions in the poll.
yes,
Are you worried about drug interactions? So we
Yes.
were actually really worried of drug interactions, because all the drugs, I think about 90-95% of the medications that we use in palliative care has interaction with methadone. So that was a worrying factor. And we also had about the QTC interval, tossed point. That was another factor. So these were actually making us or preventing us from prescribing methadone.
Okay, sir. Thank you, sir.
So there was an initial question on methadone, pregabalin, and what happened to the gabapentin, amitriptyline and pregabalin in your patient story.
Yeah. For the first patient, actually we stopped both pregabalin and amitriptyline. I told you we were not confident to continue with the medications which can cause drug interaction. Particularly, I think amitriptyline is the one which can cause drug interaction, and gabapentinoids doesn't have much interaction. But at that time, we thought keep the prescription as simple as possible. That was our plan, because so that there will not be much interaction. So we stopped both, and she was getting only a small dose, 75 milligram of pregabalin and amitriptyline 25 milligram, and with which she had no pain relief at all. So we thought we will stop it as well.
And what if ECG is not available in the setting?
Yeah, this was one of the problem that we also faced. This was especially true when we started the patients on methadone during home care. So how to take an ECG during home care? No way. But later Theo and one of our mentor, Dr. Ann, helped us to have a handheld ECG machine, and so that we took ECGs for those patients who was on curative treatment. But now we usually don't take ECGs during home care unless we feel that this patient has many risk factors. So just see whether this patient has so many risk factors, and if the patient is under curative treatment, try to get an ECG, because that patient is going to benefit by doing an ECG. But if the patient is under comfort care only, then I will not advise you to go for an ECG. So you want to look for risk factors.
So there are many other questions in the chat. When
Yeah.
a patient is started on methadone, what about the strong opioid that they were taking, or should it be given as SOS?
Yeah, I think I showed you the prescription. So when you start a patient on methadone, you have to continue with the strong opioid that the patient was taking, the immediate release morphine. So it is given as a 4-hourly SOS basis, not 4-hourly and SOS. It is 4-hourly SOS basis. That means you will give methadone at 6 a.m., 2 p.m., and 6 p.m. And if the patient was previously taking morphine 10 milligram 4-hourly, at 6 a.m., you will ask the patient, do you have pain? If the patient says, no, I don't have pain, you will not give morphine during that time. At 10 a.m., you can again ask, do you have pain? If the patient has pain, you will give 10 milligram morphine. 2 p.m. again, you will ask. Patient says, no, I don't have pain. You will not give morphine. So that's what a 10 milligram Q4X SOS means. The previous dose of morphine, what the patient was taking, can be given as SOS dose every 4 hours.
And what about simultaneous chemotherapy?
Yeah. I also had a talk with another palliative care physician who see a lot of cancer patients who have undergoes chemotherapy. They told they do start a methadone for those patients also. And there are some chemotherapeutic agents which has some interaction with methadone. I don't remember. Theo, do you remember?
So, I mean, for the most part, a lot of it's going to be discussions with the patients and the oncologist, depending on what treatment they are, and it's going to depend what exactly the interactions are. In some cases, I've had instances where discussions with oncology and goals of care where the oncologist preferred us to hold off methadone for them to finish a cycle. There are some cases where there are interactions and we started methadone on patients receiving therapy. So it really depends on a case-by-case basis and just having these open discussions. Typically, if it's like starting chemotherapy agents that are more concerned with cardiac risk, until they're done with infusions, you can always hold off therapy or starting methadone until afterwards as well.
Thank you. Are we justified to start methadone straight away?
Yeah, there are a few situations in which you have to start methadone straight away. In patients with increased serum creatinine, so it would be difficult for you to titrate morphine. But for those who doesn't have methadone, you have to start the patient on morphine. But if the patient has renal failure, CKD, then you can start directly on methadone. And if the patient is allergic to morphine, then that's also another indication to start methadone straight away.
So there are a few more questions. Shall I take the questions right now?
Yeah.
So is there any specific time limit after which we need to do a follow-up ECG or electrolytes?
So you can
Yeah, so that was covered on the last section. So I'm just going to leave that here. But typically, if it's aligned with goals of care and you're able to get it, and it's determined that we can do it based on ECG, typically we would follow up 2 to 4 weeks after initiation, or if they reach a dose threshold of 30 to 40, and then also 100 milligrams of methadone a day, or if there's new risk factors or signs and symptoms suggesting a risk. But I'll keep that a little short since that was at the last section and we're a little short on time.
And sir, how much dose you have given? What was the maximum dose you have given in your setting?
Actually, most of the patients would need less than 40 milligram, but I think one of our patients had about 50 milligram of methadone. That was the highest dose we have used till now. So I think almost all patients had a good pain relief with methadone. So I don't know Theo's experience, how much you have used.
Yeah, so I believe there's a study out there showing that for the most part, a lot of patients find good pain relief towards the 30 milligrams of methadone a day. Some may need less, but that's typically the higher end of what we see for pain management. But for my experience, I've seen patients on higher doses of methadone. And in regards to like, if you also include like substance use, I've seen patients on doses of 180 milligrams of methadone, but those are typically a little bit more high end, but that's because of substance use.
And how do we reduce the dose after some time? Do you reduce the dose after some time, and what to give as SOS?
So if patients are showing that they're not needing as much SOS dosing or not needing SOS dosing at all, or if you notice that they're having more side effects or maybe more sedated with continuing their methadone dose, that may be some keys for you to pay attention to and consider doing a slow dose taper. So slowly reducing it and see how they respond, and then giving them SOS dosing just in case if they need it. If you reduce the dose and they start needing a lot more SOS dosing around the clock, then that might be reason to go back up to their dose. And then for the SOS dosing, typically when you calculate their initial OME requirements, typically we would say 10 to 15% Q3, Q4 hours.
Maybe two last questions. What about, do you recommend continuing pregabalin and amitriptyline, which patient was already on?
I think if you are able to take an ECG, you can decide on that. But if the patient is on lower doses of pregabalin and amitriptyline, I think you can continue.
Yeah, generally speaking, I would recommend towards coming off of amitriptyline just because of similar mechanism of action and additive QT risk. But again, like Dr. Sunil said, if you have a baseline and you feel inclined to continue it, I think that's up to your clinical judgment, but I would probably err away from it. In regards to pregabalin or gabapentin, you could continue it, but if possible, I would always recommend to simplify medication regimens as possible. And there may be neuropathic pain benefits with methadone. You can always taper patients off of it while they're on methadone and see if they even need to continue it. And I would always recommend a taper to prevent withdrawal symptoms. And there are no necessary drug interactions with gabapentin or pregabalin, but there may be additive respiratory depression risk, but that's gabapentin and pregabalin with all opioids.
Thank you to you. I think we can move on to the presentation and then take the questions together. I think we still have time. I mean, we can give some time.
Okay. So with the case presentation or calculation practice, I'm going to briefly go through this patient just because I'm reusing the patient that we did last time. So it's a 57-year-old male with a diagnosis of stage 4 pancreatic cancer with mets to spine and liver, and history of hypertension, diabetes, and CKD. And they're presenting with uncontrolled pain. History of illness was diagnosed a year ago. They've tried ibuprofen, paracetamol, and a few doses of morphine, and their pain has continued to get worse. They did ibuprofen, but that caused an AKI. And then they completed palliative radiation and to the spinal mets. And then as before, labs were normal. We had an MRI showing where the lesions were on the spine. And then just to go through, they've completed chemotherapy and radiation therapy, and their analgesic history included gabapentin, ibuprofen, amitriptyline, which helped with some pain, but they couldn't tolerate the side effects and had mild confusion. They've already completed the steroid burst with dexamethasone, and then fentanyl patch is not an option for them because it's not affordable. And again, I'm going through these pretty briefly just because we've already gone through this case. So they have severe back pain showing neuropathic and nociceptive qualities. In addition to the leg pain, has pins and needles and numbness, and and it feels like sandpaper to touch, which hints us towards possible hyperalgesia. So currently, patients on the hydrochlorothiazide, 25 milligrams PO ED. They're also on insulin, 5 units before meals, and then insulin NPH, 10 units BID, and then paracetamol, 500 milligrams Q4 hours SOS. When we ask them how much they use on average 5 doses a day. On morphine, they were added up to a dose of 60 milligrams PO Q4 SOS. And when we asked them how often they use it, they told us that they've been using 6 doses a day, sometimes 7 doses, because the pain is so severe, even though that's a little bit more than recommended. So if you decided that you wanted to initiate methadone, what would you recommend? So if we do the calculations and find out how much OMEs a patient is using, the morphine that they're using consistently is 360 milligrams of oral morphine per day. And how would you do a conversion for the basal? So if their pain is uncontrolled, it's reasonable to do 100% of this conversions of their OMEs to methadone. If we anticipate that they're going to receive other therapies which may help with pain, so example, if we're anticipating that they're going to be getting palliative radiation or palliative chemotherapy, which may reduce some tumor burden that is contributing to pain, then you could consider doing a smaller conversion in anticipation that their OMEs may be lower than we would imagine. However, I want to emphasize that the conversion ratios that we're talking about on the white paper consensus are very conservative already. So you don't have to feel so worried about it. And it would be okay to do this 100% basal conversion versus if you compare that to other opioids with doing long actings, which you would consider doing a more conservative approach because these conversions already include cross tolerance and are very conservative. So in this patient, who's a 57-year-old male, and he's using 360 milligrams of morphine per day or 360 OMEs, what ratio would you guys use?
10:1, sir.
20:1.
20:1.
Yeah, so if we look at this conversion, the patient is 57-year-old male, so he is younger. However, his OME is 360. So we would actually use the 20:1 conversion. So when we do this conversion and we do the 20:1, we would calculate 18 milligrams of methadone a day. And then remembering what we spoke about before, that the analgesia benefits last anywhere between 8 to 12 hours with repeated dosing. The final methadone dose will be dependent on the formulations. So currently in India, it only has the syrup or the formulation, which is the 5 mg per ml. Previously, they also had the oral tablets. But just for completeness sake, I've included both options in the event that PO tablets come back. So generally, once we do the calculations, we would recommend to round down to the best fit for the formulation. The nice thing with syrups or the liquids is that you have more flexibility with dosing versus doing tablets. You are limited to the tablet size or up to cutting the tablet in half. But we wouldn't recommend cutting tablets beyond half since that becomes very inaccurate. So in this case, since we calculated 18 milligrams of methadone a day, if we do the tablets and it comes in 5 milligram tablets, you can consider doing 1 tablet every 8 hours, which would be 15 milligrams of methadone a day. If we are doing the syrups, because you have flexibility, you can consider doing BD dosing if you wanted to make it less frequent dosing for the patient. So that would be 9 milligrams or 1.8 ml by mouth every 12 hours. So that's a total of 18 again. Or if you wanted to do Q 8 hours, or if the patient's saying the methadone isn't providing long enough pain relief, then you can also switch to TID or 3 times a day. So you can make it 6 milligrams or 1.2 ml by mouth every 8 hours, which would also be a total of 18 milligrams. And then lastly, remember, don't forget about breakthrough SOS pain doses. So it would be, if we continued the morphine IR, 60 milligram for breakthrough pain, that's likely too much because we're adding on this new methadone for basal pain, and there may be reductions in required OMEs. So generally, like I mentioned on our last section, rule of thumb for breakthrough dosing can be estimated around 10 to 15% of total OMEs. So in this case, our patient had 360 milligrams of OMEs that they were using every day. So if we did 10% of this, we would get 36 milligrams of morphine IR, and we could be conservative and round that down to 30. So if we double check and do that Q3 or Q4 hours, we want to make sure that the patient may be getting enough breakthrough dosing. So if we made this SOS 30 of morphine available Q4 hours, that means they could get up to 6 doses a day. So then we're giving them up to 180 milligrams of morphine that they can use for breakthrough pain on top of the methadone. And we would anticipate they may be using more of the SOS dosing in the beginning while we wait for the methadone to reach steady state. So in this case, the final regimen that we would be utilizing in this patient would be methadone for tablets, 5 milligrams every 8 hours, and then morphine IR, 15 milligram tablets, and having them do 2 tablets every 4 hours as needed for breakthrough pain. Does anyone have questions right now with this conversion? Okay, so now moving forward for follow-up with this case. So let's say the patient has come back to the clinic for follow-up. They say their pain's improved. It's now a 6 out of 10. Previously it was 8, but the pain is still somewhat uncontrolled. And they're on this current regimen. And when we ask them how much SOS they're using 6 doses of the 30 milligrams a day. How would you make adjustments to their pain regimen? So if we want to consider adding more methadone or increasing the dose, a good way that we can consider going about this is utilizing this SOS OME dosing. So if a patient's requiring the 6 doses, we can calculate that up, and we are finding out that they're using 180 OMEs. And we want to make sure, did we give them enough time to reach steady state? In this patient, he was 57 and had normal hepatic function. And so what we can do is, since we convert their OMEs, you can choose to add some of it or all of the OMEs added on, depending how conservative you wanted to take the approach. But if we choose to only do 50% of that to add on to their methadone, and then we do this 20-to-1 conversion, like we were doing before, then that would equal to 4.5 milligrams of methadone a day. So when we do the dose titrations, we also want to check how much can we increase. And then since the patient was only on 15 milligrams of methadone a day, then we know the maximum that we would want to increase for any dose titrations is actually 5 milligrams a day. So in this patient, we can actually increase to another 5 milligrams. So we could switch the patient from 5 milligrams POQ8, so 15 milligrams a day, to 10 milligrams POQ12, so 20 milligrams a day. So next, I wanted to go on to special scenarios with the patient. So let's say we go back to the patients and we started them on, want to start them on methadone, but we find out that they're on fluconazole before you started methadone. What would you need to consider? So if you could switch to another medication, then we would always err towards that. If for some reason they can't switch to an alternative medication, then again, we would want to keep in mind what we talked about with drug interactions, and you may want to empirically reduce the methadone dose by 25 to 33%. So in this case, if we reduce methadone to 33%, that would decrease the dose, and then we would round down to how much we would use. So in this case, we could recommend that 2.5 or half tablet every 8 hours to start on the basal, and then provide them with sufficient SOS dosing, and then kind of monitor, and then just like before, follow up and titrate. So for another special case scenario, let's say we have a patient that's actually using 1,200 OME of morphine a day. We do a 20-to-1 ratio because we know that's over 200 OMEs. What methadone dose would you recommend? So I see in the chat, someone recommended 45, someone else recommended 40.
40 mg per day.
Great, so I'm glad that you noticed that. So regardless of the conversion factor, we want to make sure that we don't start any higher than 40 milligrams a day, and then remembering to divide the dose. So if we did the conversion, 60 milligrams would be too high to do an initiation. What about in patients that are opioid naive? So in this case, we have a 35-year-old female who presents with metastatic head and neck cancer for pain management. She was determined to be a good candidate for methadone since it may help with neuropathic pain, and her pain is rated as a 7 out of 10. She's currently taking morphine IR, and she's taking 7.5 every 4 hours as needed, and reports using 6 hours of the 7.5 SOS. So we find out that she's using a total of 45 milligrams OME per day. And then she has a past medical history of head and neck cancer, CKD, hypertension, and type 2 diabetes. What dose of methadone would you start?
1 mg Q12.
Yes. So when we look at the opioid naive dosing, you can start anywhere from 1 Q12 or 2.5 Q8. If we wanted to compare this dose to doing the conversion ratios, and if we took, and this is just for us to compare, right, because she's on 45, but if we use the 10-to-1 conversion ratio, that would actually calculate to 4.5 methadone. So it would definitely be reasonable to do the 2.5 Q12, but you could decide to do the 2.5 Q8 as well. So there's not necessarily a wrong answer, but you can always compare the conversion ratios just to give you a ballpark. So overall, for the discussion points for our discussion is determining if a patient is a good candidate for methadone, evaluate the total daily OMU requirements and factors that may impact methadone conversions and titrations. And then methadone does not have linear conversion factors, and making sure that we allow enough time to achieve steady state before titrating methadone doses. And then dose titrations are dependent on current methadone doses, whether we can increase by up to 5 milligrams or 10 milligrams, depending on the current methadone dose. And then conversion ratios with the white paper consensus are only from other opioids to methadone. And then don't forget about adding on bowel regimens to treat constipation. And I'll open it up for questions.
How to de-escalate methadone? I'm sorry, there's a question, how to de-escalate methadone?
Is there a little bit more context with what you mean by that?
Suppose somebody has got a definitive treatment and the pain is relieved, and we want to stop them of methadone, means how do we do it?
Okay, so I mean, I would say it depends on what their current dose is. If they're on higher doses, I think general rule of thumb for opioid tapering is around 10%. And then you can always decrease by that much for methadone, and then just ensuring that they have enough SOS dosing in the event that they need breakthrough pain because the methadone dose is coming down. But say if they're at smaller doses, say if a patient is on 5 TID or 3 times a day, Q8 hours, I would consider going down maybe 2.5 or 5 a day, but that really depends on where their pain is at. If their pain is, if they're still having some pain, I would probably go a little bit more conservative. But if we find that they're getting more somnolent, then I would be more aggressive with coming down on that, on the dose.
I'll combine 2 questions which has come before. One is addictive tendency for methadone, and what are the common side effects practically in your experience, Dr. Sunil?
So in regards to concerns for addiction, I would say methadone would be similar to utilizing opioids, right? I think that as long as you're monitoring it, you're starting it on an appropriate indication, and the patient is, and you're constantly following up with the patient and making sure they're using it as prescribed, then you shouldn't be as concerned about addictive tendencies, right? Because there is a reason for them to use it, and it is for pain. And then in regards to side effects, I would say methadone has similar side effects to general opioid use. The only additive one on top of that would be the risk of the QT prolongation, which we've talked about at the previous session.
Dr. Sunil has answered Dr. Sheila's question on neuropathic pain.
So we know that if the patient has severe neuropathic pain, we not only start anti-neuropathic pain agents, because tricyclic antidepressants or anti-epileptics, it will take about 2 to 3 weeks to have good pain relief. So we also start an opioid along with anti-neuropathic pain agents. So we usually start, we don't start on methadone straight away. we usually try other methods, and if not relieved, then only we will convert it to methadone. But I told you there are two situations where you can directly start patients on methadone. And if you look at, there are, I think, many people have different practices. There are some people who tells directly start patients on methadone even if they have acute pain. But we don't we don't do that. So I think for beginners, it is always good to start the patient on some other opiates and then convert it to methadone.
So, but will morphine work on neuropathic pain, sir?
Yeah, all the opioids are partially sensitive to neuropathic pain. So now definitely it has effect on neuropathic pain. It you may not get 100% pain relief, but I have to tell you that I had one patient who had CKD, then I think coronary artery disease. There were many complications, and this patient because of diabetes. And this patient's main problem were diabetic peripheral neuropathy on both lower limbs. Below knee, he had a very severe neuropathic pain, 10 by 10. And actually, this patient was started on many neuropathic pain agents by neurologist and endocrinologist, but there were no pain relief. And this patient was sent to us. So this patient was already receiving good doses of anti-neuropathic pain agents. So we just gave a morphine trial. I think the serum creatinine was about 3. But even then, we gave him a morphine trial, and to our surprise, he had 100% pain relief. The only problem that we had to monitor that patient very frequently because of serum creatinine was elevated, and he may go into toxicity because M6G can accumulate. So, opioids have a partial sensitivity to neuropathic pain.
So even in non-cancerous patients who have severe diabetic neuropathy with the serum creatinine around 2, say 2, but they are in the cardiac failure patients with CCF, is it okay to start morphine, sir, if not controlled by pregabalin and?
I think in non-cancer patients with pain, first of all, we will try with non-pharmacological managements like maybe site control of diabetes and things like that. The next step is the first step of WHO analgesic ladder, and then second step, and if not controlled, then they advise interventional pain management, and then to step 3 opioids. That's what the advice is usually by the pain physician. But I think in this patient who has cardiac failure and who has severe neuropathic pain, which is not under control with the usual anti-neuropathic pain agents, I think we can use morphine. Yeah.
And sorry, one last thing I wanted to know is on this slide that I talked about before with the drug interaction decrease. I think there was a table on the slides before with a different methadone dose. But so we just to reiterate, you would just do the if they were we calculated 18. If you do the 33% reduction, that would be 12.1. We round down to 5 milligrams a day, and then the methadone recommendation you can do is 5 through 12. So I just wanted to fix that typo on the slides I showed there.
Are there any other questions which was not answered from the chat? I hope I read out all the questions in the chat.
Methadone reduction, is it 10% every week or after 5 days, something like that?
So I would not do it any sooner than a week reduction every week, but that's I would say probably more on the aggressive end. But for recommendations with the CDC on tapering off opioids, the recommendation is anywhere between 10% reductions Q week if you want it to be aggressive. But for methadone, I would probably go slower than that, maybe even few weeks to a month. But again, it depends on the patient's presentation. If they're showing pain is very well controlled, or even signs of somnolence or excessive sedation, then I would be more keen on a more rapid taper.
I think there is one question to Dr. Sunil. Why you thought of morphine in the setting of CKD? Was it because he had not received any opioids prior?
No, actually this patient, he was on many anti-neuropathic pain agents and I think on tramadol also, and he didn't have pain relief, and we didn't had any other medication to at that time to use for that patient. We had only morphine, so that's why we tried with morphine.
Thank you, Dr. Sunil. I can't see any other question. Maybe we can wind up today's session. We overshot 5 minutes, but it was a good interactive session. I think there were a lot of questions, and I hope the faculty were able to answer your queries. But if you have more questions, please send us the questions in the WhatsApp group. We'll be getting back to you with the answers. Thank you so much, Dr. Sunil and Theo, for excellent session on methadone like last time. I hope you also enjoyed all these interactions and questions from the participants' side. Thank you so much, everyone. We'll be sending your feedback link, and kindly give your feedback so that we can also improve our sessions in the coming days. Thank you so much. Have a good night. Have a good weekend. Thank you both.
Thank you, everyone.